Okay, so we'll start with this topic today. Needle is presenting opioid substitution therapy. So we prescribe a lot of opioids for our patient, but that is not basically opioid substitution therapy as such. So just briefly talk about it.
Good afternoon, everyone. My topic is opioid substitution therapy, and my moderator is Hamza. We have opioid receptors, which are mu, kappa, and delta. And its activity is on mu receptor, it is analgesic, euphoric, meiosis, sedation, constipation, respiratory depression, hormonal changes, cough suppression, and nausea. On kappa, it is analgesia, diuresis, sedation, dysphoria, hallucination, and respiratory depression. On delta, it is analgesia and convulsion. Now we have three types of action. Agonist is opioid agonist bind to and activate the mu receptor. Therefore, thereby it exerts 100% action, producing opioid-like effect. Example is morphine, codeine, dextropropoxyphene, heroin, and methadone. Partial agonist is it exerts action less than 100% action on the mu receptor. Example is buprenorphine. Antagonist is it bind to the mu receptor, but it does not produce any action by themselves. Example is naloxone and naltrexone. Now, the principle of treatment, when a patient comes with opioid dependence syndrome, either we go for detoxification by an opioid or a non-opioid, or we give maintenance by an antagonist or an agonist, which is harm reduction. Now, detoxification with opioid, we treat the withdrawal symptoms. Withdrawal symptoms last for 1 to 2 weeks, and we give opioids like buprenorphine or methadone. Buprenorphine, it is initiated at 0.4 to 0.8 mg per day as per withdrawal symptoms, and then it can be titrated up. And 6 to 8 mg per day is sufficient to control withdrawal symptoms, and we taper down gradually over a period of 10 to 14 days. And withdrawal symptoms with buprenorphine, it resolves faster as compared to methadone. Methadone we do in inpatient setting, and we initiate with 10 mg per day, and slowly we titrate up to 20 to 40 mg per day, and slow tapering is done at 5 mg per day for few weeks. With non-opioid, we have clonidine, which is a central acting alpha-2 adrenergic agonist. It suppresses the non-adrenergic hyperactivity of withdrawal, and it suppresses nausea, vomiting, diarrhea, cramps, and sweating. However, it is not helpful in muscle aches, insomnia, distress, and craving. Now, why do we need maintenance? Because opioid dependence, it is a chronic relapsing disorder. So suppose we give for withdrawal symptoms, then the patient will relapse if we give it for short treatment. Therefore, long treatment is required. So with maintenance treatment, we give opioid substitution therapy. It is also known as oral substitution treatment, also known as methadone or buprenorphine maintenance treatment. Some people also call it medication-assisted treatment. Now, what is the criteria of opioid substitution therapy? It should be, diagnosis should be opioid dependence, and the patient is ready to give informed consent and willing to follow up. Another non-essential criteria is age should be greater than 18 years, should have long history of opioid use, poor psychosocial functioning, high-risk behavior, and history of failed abstinence. Now, what is the objective of BMT or MMT? It reduces illegal and other harmful drug use, improve the patient's health and well-being. It reduces death and other medical morbidities associated with drug use. It reduces crime committed by patient, and it facilitates an improvement in the patient's occupational and social functioning. Now, what is the philosophy of agonist substitution? Suppose we have drug of abuse. Example is heroin, which is an illicit, medically unsafe, short-acting, more addictive opioid, which is taken by injectable route. We substitute it with agonist medication. Example is buprenorphine, which is a legal, safer, long-acting agonist medication of known purity and potency, along with psychosocial rehabilitation. Next is what kind of medication are suitable for agonist maintenance. It is those agonist maintenance should have the ability to control withdrawal symptoms, should reduce desire to take illicit drugs. It should have minimum side effects. It should be easy to administer, low euphoria, low dependence potential, economically and easily available. And it should be long acting so that frequent dosing is not required. Next is, what is the context of using buprenorphine? Harm reduction. We use from illicit to licit drug, injection to oral, short acting to long acting, an unknown dose to a definite dose, unknown situation to a safe situation, secretive to supportive, and compromising to facilitative. And now we have medication assisted recovery, which is from short acting, highly salient, secretive, uncontrolled, impairing, to long acting, less salient, supported, controlled, and empowering. Now here we can see when a patient is using opioid intake, then they will either be in opioid intoxication or in opioid withdrawal. But with buprenorphine, patient will neither be in intoxicated state or in withdrawal. It will be in maintenance. Now treatment phase, buprenorphine treatment can be divided into 4 phases. It is either pre-induction, induction, maintenance, and discontinuation. In pre-induction, the goal is to minimize the risk of precipitated withdrawal. So we wait for withdrawal to appear, mild to moderate, and then because precipitated withdrawal is more intense and has faster onset than withdrawal dose due to abstinence. So with short-acting opioids such as heroin, we wait for abstinence from 4 to 24 hours. In induction phase, the goal is to titrate the patient to his ideal daily dose of buprenorphine. So what is the ideal daily dose? It minimizes the side effect, minimizes the drug craving, and there is no intoxication. Induction usually lasts for 2 to 3 days, and patients are kept under observation so that dosing can be adjusted as needed. Now, this is a flow chart on induction phase for buprenorphine. Is the client eligible for initiation of buprenorphine-based OST? If yes, is there a gap of greater than 6 hours after the last opioid use? If no, then we wait for withdrawal to appear before the first dose of buprenorphine. If yes, greater than 6 hours, then we initiate with 2 to 4 mg of buprenorphine and we observe for 2 hours. Then, does the client still experience opioid withdrawal and or craving? No, then we'll ask the person to come the next day. If yes, then we'll administer another 2 to 4 mg till a dose of 8 mg of buprenorphine is given. But we do not exceed more than 8 mg on the first day. And if the person is still experiencing withdrawal, then we will manage withdrawal symptomatically and we'll ask the person to visit the next day. And if the person is not experiencing, then we'll still ask the person to visit the next day. But more than 8 mg is not recommended. On the second day, we'll ask after the person returns on second day, we'll ask, did the client experience withdrawal on a craving in the past 24 hours? Did the client take opioid in the past 24 hours and felt a high? If no, then a daily dose is established. We'll continue with the previous days of buprenorphine. And if it is yes, then we will increase the buprenorphine dose by 2 to 4 mg, depending on the severity of withdrawal or craving, and we'll ask him to follow up next day. Maximum dose of buprenorphine on day 2 should not exceed 12 mg per day. Then we'll ask the person to return after 24 hours. And we'll ask Did the client experience withdrawal or craving in the past 24 hours? If no, then that dose is established. Then on second day, if he's still experiencing craving or withdrawal, then we'll increase the buprenorphine dose by 2 to 4 mg every day, depending on the severity of withdrawal or craving. And we'll ask him to follow up next day. Maximum dose of buprenorphine should not exceed 20 to 24 mg per day. Now in maintenance phase, the goal is maintenance on adequate dose of OST medicine. We should ensure treatment retention and prevent opioid relapse, and we should address other substance use, occupational and financial and familial rehabilitation, motivate and refer the client for the services. Now, adequate maintenance dose of buprenorphine, 2 to 4 mg per day. It controls opioid withdrawal. 4 to 8 mg per day. It's control of opioid-related craving, and greater than 8 mg per day controls opioid blockade effect. Now, follow-up during maintenance. Regular follow-up is essential, and we do assessment during follow-up is adequacy of dose, any adverse effect, compliance to OST, use of other substances, comorbid illness, and progress in socio-occupational function. Now, in termination phase, our goal is to ensure minimal discomfort during taper, to support and prevent relapse, to help make decision on further treatment, and to motivate for continued follow-up after stopping OST medicine. Now, termination phase, it should be planned and mutual. We should prepare patient well in advance, and we should also involve family members. Tapering regimen is, it should be never stopped abruptly. There are no fixed regimen. Gradual decrease in dose, patient's comfort, guiding factor, and it can be done on outpatient basis, weekly or month. It can take week or months, and faster taping possible in inpatient setting. Now, what are the indicators for considering termination? Is after there is cessation of opioid use, cessation of illegal activities, there is improvement ties with family, strong psychosocial support, well-maintained occupational functioning, and client's readiness to lead a medication-free life. And indicators for not considering termination is continued drug use, continued illegal activities, poor occupational functioning, poor social support, and risk of relapse. Now, daily buprenorphine dose and what is the reduction rate? If we are giving buprenorphine above 16 mg, then 4 mg every 1 to 2 weeks, we reduce it. If it is 8 to 16 mg, then 2 to 4 mg every 1 to 2 weeks. 2 to 8 mg, then it is 2 mg per week. And below 2 mg, then we reduce by 0.4 to 0.8 mg per week. Okay, after OST, what next? If the patient is motivated enough, then one alternative is drug-free. It is, but we will ask the patient to follow up for 4 to 6 months, or we can give naltrexone. It is initiated after opioid-free period. Now we come to methadone. It is a synthetic mu opioid receptor agonist, which is a slow onset and long half-life, and reliable absorption and bioavailability is 70 to 80% after oral administration. Delay of peak plasma level until 2 to 6 hours after ingestion, and it is 90% bound to plasma proteins such as albumin, globulin fragments, alpha-1 acid glycoprotein. Buprenorphine binding to tissue, it creates a large reservoir of methadone in the body, contributing to long duration of action, hence requires administration just once a day. Now, MMT dosing is, we start with once a day dosing. We start low and we go slow. And we will look for withdrawal signs prior to dose 1. We initiate at 20 to 30 mg. It can be less than 10 mg also. A first dose should not exceed 30 mg per day. And we continue same dose for 3 to 4 days. And we increase by 5 mg every 3 to 4 days under supervision. The target dose for methadone is 40 to 60 mg per day to block withdrawal symptoms, 60 to 100 mg per day for decreasing craving and illicit opioid use. And the preparation is 5 mg per ml of liquid, and it is available in tablets of 5 mg, 10 mg, and 20 mg. Now, this is the treatment algorithm for methadone maintenance. The criteria for suitability is patient should be opioid dependent, long duration of opioid use, willing to comply with treatment requirements and provide informed consent, failed abstinent attempt with short-term treatment or with other agonists, example buprenorphine, or in pregnancy, it is more evidence is there for methadone. Now, initiation of induction is methadone is 20 to 30 mg when withdrawal symptoms begin, and we increase dose of 5 to 10 mg at interval of 3 days. And optimum dose is when there is no withdrawal, no craving, and no side effects. Now, with methadone, there is chances of torsidipoitis and QT prolongation. In borderline prolonged QT in females is greater than equal to 470, and in males is greater than equal to 440. So we will ask to repeat ECG. We'll send electrolyte, and we'll try to modify QT risk factors. Example, cocaine use, methadone dose, and psychotropic medication. If prolonged QT is greater than 500, then we'll repeat ECG. We'll send serum electrolytes, and we will see other cardiology and addiction specialist advice. And if it is greater than 550, then we will do urgent cardiology reference. Now, the side effects of methadone is constipation, increased appetite, weight gain, and lower libido. This is a comparison of methadone and buprenorphine. Methadone, it appears to be more marked and prolonged, best for maintenance program. And buprenorphine appears to have milder withdrawal syndrome than methadone, and therefore may be preferred for detoxification program. Now, difference in initiation. Methadone is associated with increased mortality during the titration phase. A need for gradual titration over a few weeks to reach the therapeutic range, 60 to 100 mg per day. With buprenorphine, it is not associated with increased mortality during titration. Able to reach the therapeutic doses 12 to 16 mg OD over a few days. Now, difference in retention. Methadone is associated with greater retention in treatment than low-dose buprenorphine. And buprenorphine is associated with greater dropout from treatment, only prescribed at low and flexible dose. Adverse effect, methadone may be associated with QT prolongation and torsidipoitis, which is a particular concern in patients prescribed QT lengthening antipsychotic or those with comorbid cocaine use. Buprenorphine is often prescribed as less sedating than methadone, which can be seen as undesirable by patients. Now, chronic pain. Patient with chronic pain condition that requires additional opioid analgesic may have difficulties in being treated with buprenorphine because of blockade effect, although in practice, this does not appear to be a major problem. And buprenorphine appears to provide greater blockade effect than doses of methadone, which is less than 60 mg. In pregnancy, methadone is widely used in pregnancy. Buprenorphine is associated with less severe neonatal withdrawal symptoms. However, it should not be initiated in pregnancy or switched to from methadone because of risk of inducing withdrawal in fetus. These are my references.
So questions and comments, any questions that you have for no questions? The use of tramadol, will that also be considered as opioid substitution therapy?
So in certain articles I read that tramadol is good for short maintenance, short withdrawal, but for OSP it has not shown anything.
Yeah, the presentation tramadol. Opioid substitution therapy में tramadol is also has been used, but it is not that much popular because of the adverse. So, methadone and buprenorphine are safe. जो कहते हैं लॉन्ग एक्टिंग tramadol का लॉन्ग एक्टिंग नहीं है, tedious dosing देना पड़ता है, करने को तो बढ़िया हो जाएगा. Because of that, but you can use tramadol also for opioid substitution. But वही है opioid substitution का मतलब using for long duration, like more than जैसे 2 weeks में वैसे usually detox करते हैं ना, manage करते हैं, using for months together, longer duration, where the patient can rehabilitate and then you slowly try to decrease that. There are articles in that also, but tramadol is this. Okay. Any other question? Why don't you use methadone?
So methadone is a longer acting, so it gets accumulated in the body. So it has to be done in the supervision. So in
That's
outpatient,
why we are not using methadone.
because it is not available,
It is not.
that
It's not available. In some centers in Delhi or those times available, it was bought like imported, but it's not available.
constipation is one of the most common side effects. And decreased libido.
That you said in methadone.
In buprenorphine also.
Similar side effects. So is there any specifically methadone where efficacy interval का problem? Okay. Why do we have toxicity in methadone? Mortality जो है methadone में है और buprenorphine में नहीं. You know reason for that.
So it takes longer acting, so it gets
Yeah.
So methadone is a long acting. So it takes a lot of time to
बताया ना agonist, partial agonist, antagonist. तो methadone किस category में?
agonist.
Buprenorphine.
Partial agent.
That is one. So if methadone person abuses opioid over methadone, then it's going to be buprenorphine will come in. Okay. In fact, in respiratory depression caused by opioids, sometimes anecdotal reports of using buprenorphine reverse the respiratory say depression is okay. So that is say receptors की तुमने बात करी, उसमें भी है ना जो respiratory depression cause करते हैं, तो buprenorphine has lesser density to cause. Methadone acts on all the receptors that it has, so it will have an additive effect if somebody abuses with, and that is also the reason in patient. Okay. Any other questions? Comments? Yeah, please. My question to you, in what cases you will not consider OST as first line? As a physician, which you may think that OST, like, not consider OST as first line. Are there any कहाँ पे हमको डीप फ्रेज कहाँ पे हम डिटॉक्स ज्यादा करते हैं? ठीक है, मोटिवेशन ऑफ द पेशेंट, हाईली मोटिवेटेड पेशेंट,
Follow.
whatever.
You can come up for regular follow. Because we titrate the dose.
ओपीडी में तो कम करते हैं, इनपेशेंट के लिए अगर रेडी हो जाएगा पेशेंट तो उनको हम जो है उसके लिए आता है शॉर्टर ड्यूरेशन इज अभी एडिक्टिव, अगर 2 3 4 डेज भी कोई लेगा तो उसको अगर बनता तो कोई आएगा कि मैं 2 वीक से यूज कर रहा हूँ, then you should not go for wasting that thing. When longer use, longer duration of use, failed abstinence, when the person is failed, like you are assisting, you know, उसमें OST नहीं करेंगे हम, we can use opioid short term for relieving the withdrawal symptoms. Opioid can be used in 2 ways. We can use an oral opioid substitution therapy where you give for longer duration at higher dose. And to manage the withdrawal symptoms, we at shorter doses and we taper quickly. We can use buprenorphine also. We can use putting both patients over. 10 टैबलेट दे दी और कहा कि इसको कम करते हो बंद करो ना, और उसमें पर ये है कि इफ इट टेक्स जहाँ पर नहीं है, मतलब कि जो उनको करना है तो फिर 8 मिलीग्राम करेंगे, जहाँ पे अगर वो यूज भी करेगा तो उसको वो नहीं होगा, नहीं। और एमजी के डोजिंग क्या है, तो जैसे कोई डिटेल्स देते हैं, ठीक है तरीका देने का।
Seven first day, we give 8, the maximum 8 mg.
जैसे 8 mg 4 mg दिया पेशेंट, ठीक है, उसको क्रेविंग हुई, तुमने फिर से उसको क्रेविंग दे दिया 6 mg के बाद, उसको क्रेविंग नहीं, कि तुमने नेक्स्ट डे बोला, अब क्या करो? ठीक है, सेकंड डे पे उसको क्रेविंग 6 मिलीग्राम हो, अब क्या करोगे? डोज क्या रहेगी? नहीं, once daily, twice daily, 3 times कैसे? Once daily is okay. Okay, you can be once daily. 4 milligrams, 6 milligrams, once daily you can do. Okay, can be once daily. Not necessary that you do. But तुम divided dose में भी तो गए तो उतना कोई वो नहीं होगा, but if a person can tolerate, तो 4 to 6 milligrams once daily also. फिर क्या करो? 6 मिलीग्राम पे स्टेबल है, फिर क्या करोगे? ठीक, कब तक करोगे? यार कब कब तुम सोचो 6 मिलीग्राम पे 3 महीने से चल रहा है, फिर आप क्या करोगे? हर बार हम पेशेंट्स को पूछते हैं एवरी टाइम बिफोर प्रिस्क्राइबिंग टेस्ट, आर दे विलिंग, जो फर्स्ट पॉइंट है तुम्हारा म्यूचुअली agreed upon, ना? यस, ये ठीक है, टर्मिनेशन should be planned and mutual. You ask the patient कि काम कर दे, बंद कर दे, अगर नहीं डॉक्टर साहब चलने दो, चलने your but you counsel him and the family members. This is also kind of, you can say, dependence, because if you don't get it, you will go into it. वो लेने से पहले काउंसिल करना, ठीक है? Any answers you have to the question which you face daily? कई बार होता है ना, पेशेंट कहता है मेरे को एडनॉक नहीं अच्छी लग रही है, कई बार होता है कि तो मेरे को सूट ही नहीं करी, क्या हो सकता है? मैं कोई आगे विड्रॉल में जाए, आपने देखा है पेशेंट? कैसे per day? My question is if to put marking when in withdrawal.